thing, so nobody will really know who's who.
Yeah, it was good. Yeah, it was just, yeah, I don't describe it. Yeah. Floating around doing stuff. Yeah.
We're recording. So, what is the question one? Adam, what is the significance of a white cell count of 1 by 10 to the 9?
Means that the immune system's
In what way?
compromised immune response. Like cells
What means what?
means it can't fight off
Can't fight off
infection.
infection.
Effectively.
Yeah. So that's the significance to the patient in the sense of their immune system is less. Always phrase everything in normal, more than, or less than, and then pathological or not. So what is the problem from the patient's perspective? What are they more at risk of? Yeah, getting infections. So from our perspective, what would we do differently? Yeah, nothing, because that's what we do with everyone. In the ICU, we glove and gown with everybody. Yeah, and we're all wearing masks all the time anyway, so really, nothing. It's absolutely no difference to us. So the more important part of this is what patients are likely to have a very low white cell count. In what way? Chemotherapy. So yes, cancer, but that think about the cancers of your white cells. What are those called? Leukemias and lymphomas, where you have too many white cells. Yeah. And what makes white cells? And how do you kill the cancer? Kill the bone marrow with chemo and radiation. And what's that going to do to your bone marrow? Cook it. And then do you have bone marrow anymore? So do you have white cells? So then what do they do? No, there's no more white cells. Yeah, but why are you killing off their bone marrow to stop the cancer? But then what's the treatment after that? You just walk around with... Do you walk around with no bone marrow anymore?
Bone marrow transplant.
Yeah, bone marrow transplant. And these are all these things. You'll see these words, yeah? This is what they mean. Yeah? All the AML, ALL, they're all 3-letter acronyms ending in L. And then they get chemo and radiotherapy, and then they have no white cells, and then sometimes they end up getting sick. Words like neutropenic sepsis, neutrophils, and so on. So yeah, that's the ins and outs of it. Who else, other than those people, will have an impaired immune response? So effectively, we'd have the same precautions.
There's neuro people.
In what way?
There was this girl I did. I can't remember what she had, but something to do with like. I can't remember. She had something to do with her hips, and she said it was like a neuro thing, and she said she can't take the treatment.
I don't know. So who else? So imagine some people that have, I don't know, had too many turmeric lattes or some other immune booster. Is having too much immune system bad for you?
Yeah.
And what diseases are too much immune system? Autoimmune diseases. Yeah. And a classic autoimmune disease is...
Something like that.
Yeah, RA. That's it. Oh, yes. Yeah. Anything itis. Anything itis is inflammatory. Yeah. And what is the treatment for inflammation? Anti-inflammatories. And what's the best kind of anti-inflammatory? Steroids, as opposed to non-steroidal. Everyone says NSAIDs. It's like, what's the not NSAID? So steroids. Steroids suppress your inflammatory response. If they suppress your inflammatory response, do they suppress your immune system? Yeah, and they make you more at risk of infections. And all these things come into it. Who's some people that you would otherwise medically want to suppress their immune system? So other than transplants. So here we do kidney transplants. At Vinnie's they do heart and lung. I think they do make liver. It's at RPA, and they do stuff. So yeah, they will be immunosuppressed so that they will tolerate somebody else's kidney or organ. Does that make sense? So what do we do differently? Nothing. We do the same stuff we do in the ICU always, which is why I just tell you do that because it's easier than trying to work out who you need to do that for. There's glove and gown. We wear masks for everyone. Wash your hands on the way in, wash your hands on the way out. The extra level of protection is just use as few people as necessary. Yeah. So if the patient's pretty much independent and walking around, you just got to wander in there with a chair, get them to sit in the chair, walk around the room, and remember, ICU, there are people outside trying to kill you, i.e. with bugs. So they might just be stuck in the room doing laps. Yeah, and that's all you can do, then that's all you can do. Does that make sense? All right, question 2, Sarah.
So decreased platelets.
Yep.
And the value for indicator is less than 50 times 10 to the 9.
What is the normal range?
The normal range is 100.
The normal range is
More than 50?
there. 150 to 450.
Yeah.
And so less than 150 would be low.
Yeah.
So thrombo is, what does thrombo mean? Clot. Cyto means, or site? Cell. Site means cell. And penia means
Density?
lack of. Greek, for some reason. Some stuff comes from Latin, some comes from Greek. Like osteopenia.
Yeah, that's
Yeah?
where I was going.
Yeah.
Density.
So it's a lack of bone density.
Yeah.
Yeah. That's so. Hopefully, part of all this is helping you deconstruct words in their origin, like the roots. I'll send you a really good YouTube clip where somebody, like one of those nerds like me, has gone through and found the origins of all these words, and it's like, I like that. So a lack of the cells that clot. So what's the problem?
They are
Excess bleeding. So what should we worry about?
if they've got like a surgical site
Yeah.
of the wound,
Yeah.
to extra careful of it.
Yep.
So things like bruising, knocking into stuff,
Don't-
things like that.
Don't punch them.
Yeah.
So yeah, in and around surgical sites, just remember they got lots of holes in them. Yeah, like cannulas and all that kind of stuff. Make sure that everything is secured and well reinforced. Is there anything? So would that contraindicate mobility?
Maybe if it was less than 25 was extra, right?
No.
Still fine.
No. So what wouldn't we do? What's some things that might actually cause bleeding that we do physio-wise?
Excessive strength, like fitness,
This is ICU or thereabouts. Think about what we were doing yesterday in the ICU that might cause bleeding. Suctioning. Yeah, so that's the less than 25. Probably don't suction them unless necessary. Yeah. Now, what makes platelets? Same place that you make white blood cells, which is in the bone marrow. So who's going to have low platelets? The same people that have had chemo/radiotherapy. And there's various other things that chew up your platelets, like getting COVID, or in some people getting the COVID vaccine, or in some other genetic things. That's actually the person we saw in ICU that has the intracerebral bleeds. Yeah, they have a thrombo something. What does thrombo mean? Clotting. Something something means sad face. Yeah, I don't remember all of this, but I can look at the person and go, that's what happened. Yeah. Why? Thrombo something. ITP, apparently, what the acronym is. Does that make sense? All right, question 3, Haley.
So, subjective method in less than 11 points. Oh, sorry, white cell count is less than 11 times greater than.
Less than?
Oh, greater than, sorry. They said to the 9. And then,
So high white cell count, more than 11, yep.
yeah, and then increased temperature above.
And a high temp. Yep. Fair enough. Very common. What other things? What other numbers that we commonly measure might be astray? Like think about all the OBS that we know they check on all the patients all the time. What might happen to some of those OBS? Panic. So what is panic? Heart rate goes up. Why in this case would their heart rate go up? You've all been sick. How do you feel? Your temperature goes up, so why would your heart rate go up? No, you're trying not to have an adrenaline response, but it's a similar kind of thing, that it will look like panic. What else goes up in an adrenaline response? And? It's gone. Somebody clean that off. What was the other thing in panic? Respiratory rate. Yeah? Why? Because you feel like you're dying in the end stage, but even low grade. So let's just put temperature into that box. What's your temperature going to do to your metabolic rate? Yeah, because as you increase in temperature, what happens to the rate of chemical reactions? Increases. So for every 1 degree Celsius, your temperature goes up. So you go from 37 to 38, your base metabolic rate goes up by about 10%. Yeah? So if your temperature is 39, you are running a marathon, lying down. So does that mean you're going to have to eat more carbs and need more oxygen and need to clear more CO2? So is that going to make your respiratory rate go up and your heart rate go up? Yeah. Now, what else happens in an infection? Well, all pathologies look inflammatory. Yeah. So you've got a infected big toe for, I don't know, your ingrown toenail. How does it look? That's if it's got pus. So that's another good sign. Pus. Yeah. Coughing up yellow stuff. Pus. What else? Yeah, we said inflammation. Swollen. Why? How? Correct. So blood is going to the area. How do you get more blood to an area? Vasodilation. All pathologies looking inflammatory are vasodilation. So locally you have bigger blood vessels and increasing permeability of the epithelium. So the cells, whatever the problem is, the cells, more cells go there in your blood, and whatever is needed does the job. So if you're bleeding, what cells do you need? Platelets. If you've got infection, what cells do you need? Yeah. And if you're just doing more work, what cells do you need? Red blood cells to deliver oxygen. Yeah. If you are doing more work in your quads, do you want more oxygen to your quads? Is that going to be vasodilation? Yeah. Feeling the pump. At the gym, feeling the pump. Same thing, vasodilation. So if you vasodilate locally, redness and swelling. Now, what if you have, say, the diabetes and you don't fight the infection off there and it gets into your blood and into your system? What are you going to have? Yeah, septicemia, as in septic infection, emia in the blood. And a systemic infection will be a widespread inflammatory response. Yeah, you'll ever had like proper flu, or as I had after my COVID jab, the full body aches. Does a full body ache sound like a full body inflammation? Is that going to be a lot of vasodilation? And what will that do to your blood pressure? Drop it. Do you want to have a low blood pressure? So how do you compensate for the low blood pressure? Increase your heart rate. Does that make sense? And then to the end point is your septic shock and whatever else, but we won't talk about that. Yeah, does that make sense? So high heart rate, low blood pressure, respiratory rate would be up because you feel stressed and you're doing more work. Yeah, redness, swelling, and all that kind of stuff. If it's a local thing, like redness and swelling aren't an objective measure, but if you stuck a tape measure around somebody's knee and then measured the other knee, is that an objective measure? Yeah. Yeah, and then the yellow or green stuff, you know, from the wound or coughing up or whatever. Makes things obvious when they're obvious. So other than bacteria, what else cause infections? Virus or fungal. Like just think athlete's foot. Yeah, candida or tinea or whatever that is. Yeah, can those things create problems other than just locally? Yeah, they can. So your classic viral is, well, the COVID or the influenza or anything like that becomes systemic. Yeah. So if you have bacterial infection, you get antibiotics. If you have a viral infection, you get antivirals and or vaccinated to stop you getting it in the first place. And then fungals is antifungals. Yeah. You get old Dactara or whatever you put on locally, but you have systemic ones as well. So first and foremost, always they have to treat the problem and then support the person. So if you've got a really low blood pressure, how can we increase your blood pressure? Yeah, put fluid into the system. Fill the balloon, more pressure. And some of you guys have seen some of the drugs we use. So if the problem is vasodilation, then what would we want to do? Vasoconstriction. Do you guys remember the name of the one we saw yesterday? Metaraminol. Yeah. Brand name Aramine, it's a common one, and noradrenaline. Noradrenaline is not the opposite of adrenaline. It works with adrenaline to cause, both of them cause peripheral vasoconstriction. And peripheral vasoconstriction is the opposite of dilation. The problem's dilation, the solution is constriction. The solution is treat the problem, yeah? Don't just throw Band-Aids at somebody. Stop the bleeding. Yes, but you're also treating the problem, and then you're Band-Aiding the brain so that the brain doesn't die. Because what happens if you don't have enough blood pressure? Why? Perfusion pressure. So perfusion flow rate and perfusion pressure. That makes sense? So you need two things, not just flow, because you'll have high flow when you're vasodilated, but you won't have enough pressure to push blood uphill through a solid organ and out the other side. So what's going to happen to oxygen delivery to your brain? Yeah, and will you be standing up or lying down? Yeah, and most of you have experienced this. Yeah, that's it. That's what it is. Make sense? Any questions on that? Because that is a lot of complex stuff. Yeah, we'll come back to this in various ways when we're talking about heart. And I'll show you a nice little flow diagram to work this out. Where are we? Question for Ornan. Is the high end of normal or the regular end of normal? What would the low end of normal be? So less than 50? Why is that important? So part A, if your kidneys aren't working, this number, your creatinine or your urea would be off. Yeah? And so if your kidneys aren't working, you have got a low urine output. What happens to the volume of blood in your system? Well, what happens to your fluid volume in your system? Increased. And what will your blood pressure be? High. So that's problem A, low urine output, high blood pressure, kidney failure. Problem B is, when else would you personally had a low urine output? Dehydrated. So what is your blood volume at that point? Less. So for any reason that you have a low blood volume, dehydration or hemorrhaging, you'll have less urine output. What else will make your blood pressure low? Sepsis. Anything that makes your blood pressure low, your kidneys will think, this is a low pressure, let's retain fluid. Yeah? If your heart isn't working very well, is your blood pressure and cardiac output going to be happy or sad? Sad. And if your cardiac output is sad, will your kidneys want to get rid of water or retain water? Retain water, yeah? The renin-angiotensin system. Aldosterone, cortisol, all those words come in there. But just think renin, renal, angio, blood vessel, tensin, tension. That's it. I will never explain it further than that because it doesn't matter. Kidneys, blood pressure, they go together. Yeah. So having a low blood pressure, your kidneys should try and help. In the long term, I guess having high blood pressure, is that good or bad for your kidneys? Bad. And then you will end up with the problems later down the track. But that's when you're 40, not when you're 15. Does that make sense? So it's one of those things we just randomly read in the patients, and particularly post-surgery, you reckon the person's been under a lot of stress? Yeah, and will stress change your urine output? Yeah. Now, there's stress, low urine output, good blood pressure or high blood pressure, and then there is stress because you've been hemorrhaging and whatever else, low urine output and low blood pressure. Yeah? So you put that low urine output and the low blood pressure as three problems. Problem A, problem B, and the combination of those meaning extra sad face. Yeah? Because you can have one or the other, not too sad, but both of them is triple sad face. And therefore, what's the likelihood that the person might fall down when we stand them up? Yeah. And it's just a very simple thing that you read. Yeah? Ooh, urine output, sad face. Be careful. Because we stand people up all day, every day. What is our job? To not drop them. Any monkey can stand a person up. Having something soft for them to land on that's not you is the intellectual property that you bring to the situation. Yeah? That's all. It's all these things, like, back to the stuff above, like what of those would indicate that somebody might be more likely to fall over? White cell count, temperature, blood pressure, heart rate, respiratory rate, yeah? The more sad faces you have there, the more careful you need to be. Yeah? Your irritability scale when you're doing musculoskeletal, remember that? Same thing, happy face, sad face. Yeah, that is literally your visual analog scale actually has the happy faces and sad faces on there. That's where I get this from. It's like, let's take something really simple that everyone understands and just make it really simple so they understand. Yeah? More sad faces, more careful. And if you have too many sad faces, you go, maybe later. Maybe later this afternoon, maybe tomorrow. Yeah, and we know the things that can be fixed and the things that just need time. Yeah, so if somebody has an acute infection, maybe wait till tomorrow. Yeah, they're on the downswing and wait till they're on the upswing in terms of the numbers. The numbers don't have to be great. They just have to be not getting worse, let's say. Yeah? And as you know, say the amount of inotropes, the things for their blood pressure are coming down, we can do more work. Yeah, if they're going up, person's more likely to fall over, do less work. Yeah? Can you always ask any of these people to cough? But can you get every one of them out of bed? No. Alrighty, where are we? Question 5.
The normal respiratory rate is 12 to 16 breaths a minute.
12 to 16 breaths a minute is the normal range. How do we measure respiratory rate? I'm going to measure your respiratory rate. What does he do? Starts doing that. Is that an efficient way to do it, or an effective way? How? What's the med student / Viva answer to this? Yeah, I'm going to take your pulse, and you take the pulse for a short period of time and go, yep, pulse is whatever, and then you're looking at their respiratory rate, pretending to take the pulse. As soon as I turned my head to look at him, he went, yeah. Yeah? Now, back to, let's look at Ornan over there. Yeah? As soon as we said, let's look at him, he started taking deep breaths. But before then, could you actually see any of him move when he's breathing? No. So how do you know he's alive? His eyes are open. You don't have to do anything. His eyes are open. Does he look like he's in any kind of respiratory distress? So do I have to measure his respiratory rate? So what are your signs of respiratory distress that you should measure their respiratory rate? That would be the endpoint. So death is death, sure. Your eyes are open. Back to, first and foremost, your eyes are open. You're not actually dead, and I'm not calling a code. What would be moving that isn't moving on him? What part of your chest? Upper part, yeah? It would be visibly obvious that your chest is moving as opposed to barely obvious that your chest is moving. Yeah? Maybe? Yeah? You can hear them breathing. If you hear somebody breathing, like we don't hear each other breathing, do we? If you can hear somebody, that's work. Are they doing more work? So do they have a high work of breathing? And therefore, should you check their respiratory rate? Yeah. What else? So what will be moving other than their chest? What other things move when you're in distress? You're looking at somebody. Just the very first thing you know is what you see. Which ones? Upper traps doing what? Elevating your shoulders. So are your shoulders moving when you're in that kind of distress? Now, why are your shoulders moving? Not lungs, but the ribs. Yeah. So thorax, yeah. So how does moving your shoulders help move your ribs? How? What muscles are you using? You are correct, but what muscles are you bringing into the game? So you're leaning forward. That's the other one. Yeah, your classic lean forward, bracing. Old bloke reading the form guide today. Yeah, you will see that. He's got the form because the Melbourne Cup's on, and he's leaning on his elbows. So what muscles am I bringing in? Pecs, you said? Which pecs? Why major? Why minor? Is to the ribs, plural. Where does your pec major insert? Sternum. Is sternum a rib? So is pulling on my sternum going to move my lungs? Which we'll get to why I don't want you using those other words you're all about to use, because I will be very unhappy. So your pec minor is anterior from the, what's the lumpy bit there called? Underneath it? Starts with a C. Coracoid process to those ribs. Yeah? Does that look like it will pull my ribs up if it contracts? And if my shoulder stays up or still, it will move my ribs, as opposed to protracting the shoulder. What's the other shoulder protractor that also pulls on ribs if you... Serratus anterior. Yeah. Medial border of the scap to those ones. And is the line of force up and out? Yeah. Those are accessory muscles of breathing. Now, in order to do this, what muscles do I need? You said before, traps and... Before that, we get to that, levator scap. Yeah? Where do they attach? The front or the back of your head? So if they attach to the back of your head, what way will your head move? Now, do you want your head to do that? So what do you need to contract to stop your head doing that? Those ones, yeah? Sternocleidomastoid. Any of those words a rib? No, so they're not breathing muscles, they're signs of distress. This is where people combine two things into one idea. It's like, no, distress, and what's the other ones? Your deep neck flexory things? Scalenes, they attach to your first rib. I guarantee most of you can't find the first rib on expert. I guarantee at week 5, you'll get it half the time. I know for a fact most people don't know how, because people trying to teach this can't find the first rib. That's all. The first rib is it's the size of my little finger. You reckon if I'm pulled on that, it's going to do much for lung movement? So do scalenes do anything for your lung movement? No, they stop your head flapping around. You ever watch like the Olympics or the Ironman or whatever, and there's somebody running across the line, like breathing like a horse? Yeah? That's it. What are they doing? They're using their head as an accessory muscle to breathe. Why? Because all those muscles are working so hard and they can't control their head anymore. You've all seen that, yeah? You've all, run in at something at the footy and been like, what are you doing? Yeah, and using that to push forward because your other muscles want to go back. Yeah, you're pulling your ribs up. What's the other version that people do instead of putting their hand behind their head? Hands on the knees. Which one's more effective and more efficient? Hands on knees. Yeah. But are you in your right mind when you've just run really hard or had an adrenaline response? No. So do you do the more efficient one or the one that you just do because that's your instinct? Yeah. That's all. Hands on knees. Interesting story on that. Michael Jordan. You know how all basketballers have shorts down to their knees? Before Jordan, they were the short shorts like AFL players wear. And Jordan wanted longer pants, so when he was short of breath, he could grip his pants when he was short of breath to give him more recovery faster. And Michael Jordan changed the length of shorts for everybody in the NBA. Yeah, because he wanted longer shorts, and he had them make him longer shorts, so he had something to grip onto to help you with his accessory muscle use. Yeah.
Well, even in school, like in training, you're always taught to put your hands behind your head and your chest up.
Yeah, more efficient. That's all. And, thinking about our elderly folk, they put their hands behind their head. No. So their recovery position will be leaning on a table or hands on knees. Your back against the wall. Yeah? So how do I know I need to measure respiratory rate? Well, even simpler than that. When you say, good morning, Bob, and Bob speaks in a full sentence like I do, does he have a breathing problem? Whereas if Bob talks in only 2 words or less, does Bob have a breathing problem? That's it. Straight up, words per breath. Beautiful, beautiful objective measure. If that's off, check all the other stuff, but it tells you very quickly, Bob's problem is shortness of breath. Look at how he looks, look at everything else, whether he's got his oxygen on, the classic oxygen on the forehead. Yeah? You're getting 2 liters a minute in your forehead. Is that an FiO2? No. Back to when somebody says, oh, and how do you convert liters to FiO2? You say, no. Just say no. If anyone has a problem with that, ring me. I will yell at them. You do not convert liters to a percentage. It is bad math, and it offends me that people do it, because it doesn't work that way. Yeah? And the classic is nasal prongs in the mouth, in the nose, breathing through their mouth. Yeah, as we see many people do. Much of that oxygen going where it should? No. As opposed to somebody that's like slowly and calmly doing their yoga, then more of that oxygen is going into their lungs. Yeah. So the same 2 liters a minute give you 2 different numbers in 2 different people. So just go 2 is 2, their sats are their sats. What number sats do we want to chase? 94. Why? Because 96 creates more problems than 94. Yeah? So if you run 4 liters through somebody's nostrils, you reckon their nostrils are going to block up? Yeah. So run 3 or 2. Works better. Make sense? So yeah, the signs of distress are all those things we talked about. Yeah, the accessory muscles are just those ones and those ones. Very important point. Everyone get in the classic student position. Take a deep breath, everyone through their mouth. Again, think about how that feels. Now just sit straight. And everyone take a deep breath. Everyone got quieter except him. Literally. So that quietness is work of breathing. Did everyone's work of breathing improve? Yeah, everyone got quieter. There's always one person that doesn't. I'm not picking on you. So what did we just change? We just changed the angle at your hips to the earth by about, 15, 20 degrees tops? And how much better did your work of breathing get? Yeah. So imagine somebody's in a shitty position in the bed, slumped, and you just slide them up the bed and just reset them at the 30 degrees they can be at, but in a better hip position. Is that going to improve their breathing? Yeah. Why? Why does that improve their breathing? FRC is the answer to all questions. Not breathing, but FRC. So if you have more FRC, you have more open lungs. You have recruited alveoli, you have less resistance to flow, and you have all of those things. Yeah? So the answer is not, I'm going to auscultate this person that looks in a bad position. The bad position is the problem, not the auscultating. Yeah? We'll get around FRC in 6 different ways. I'm going to find who stole my slinky. I know who stole my slinky, I just want it back. Now everyone stand up. Stick your fingers in your beer belly. Take a deep breath. You feel your abs or your obliques or whatever contract. So are your abs an inspiratory muscle? You get taught scalenes and you don't get taught abs. That bothers me. Your abs are an inspiratory muscle. How do I know? Well, Google paradoxical breathing and Google who gets paradoxical breathing. People with a cervical spinal injury. Do they innervate their abs? Yeah, because your abs innervate from about T6, T8 or something. So if you don't have abs, you have paradoxical breathing. Does that sound like it's good for you or bad for you? Yeah, and the opposite of bad for you is having abs when you breathe in. Yeah. Again, this whole weird, people misuse concepts like tummy breathing and diaphragm breathing, whatever. It's all just, your abs contract when you breathe in. Yeah. So how do you stop your abs contracting when you breathe in? Lie down, flat on your back. Your abs going to contract? No. Sit on the edge of the bed. Do your abs have to contract to stop you falling over? If your abs contract, you get better gas movement and more lateral basal expansion. See how that works? The chair is not the solution to the problem. The way you get from the bed to the chair is the solution to the problem. Yeah? Because if you're in a chair and our chairs go really reclined, you're basically in a bed if you're not fully upright. But how you get to sitting on the edge of the bed and standing and all those things we just did, they make you engage more muscles. And if you engage more muscles, you stretch your lungs more. Yeah? And if you engage more muscles and do some steps or marching, are you doing more work? If you do more work, does your brain tell you to pull harder on your lungs? And then do I have to ask you to take deep breaths? Because you have more FRC, so I don't have to ask you to take more deep breaths. And you feel stressed, so you're taking deep breaths anyway. And so once they're well positioned and seated and they're not going to fall down, then do you ask them to cough? And does that succeed in clearing the problem most of the time? Yeah. And if not, we add all the other sputum clearance stuff, yeah, that we've done last day or so. Does that make sense? Yeah. So don't focus on the numbers, focus on why the problem is the problem, and most of that is position. And what do we do as physios? Yeah, I'm the push that makes you move. Yeah, that's all. Yeah. We'll go through that next week, but yeah. And just think the opposite of that is having a spinal injury. Happy face or sad face. Yeah, we'll talk about that. So next week's long week, we'll talk about it then. So, where are we? Bad. Question 6. What kind of bradycardia? Sinus rhythm, but it's not sinus rhythm normal, it is sinus rhythm bradycardia. Yeah, because it is less than? Yeah, and what's the normal range for heart rate? 60 to 100. So sinus just means the QRSs are nice and evenly spaced. Yeah? People get confused about ECGs because they're trying to find the pathology. You don't have to. There's a person that's an ologist that handles the heart. What's his name? Cardiologist. You reckon he's going to have looked at this problem? Read his notes. This is a hospital. You're not out somewhere rural trying to use the force. Also, use the force. Stick your hand on somebody's blood pressure finding areas, or carotid or pulse or whatever finding areas. Feel their pulse. Happy face or sad face, fast or slow, even or uneven. You know that in about 6 seconds. Yeah? It's no more than that. If somebody's going, you reckon that's fast? No. If they feel okay, 60 to 100, do I care that they're 75 or 65? No. I care that they're not 165. Yeah, or 5. Yeah, because very few people are going to have a problem anywhere between 50 and 120. Yeah, you won't have a problem at 140, would you? Nah, that's all. Just have one of these coffees. Jesus, we overdid it on the caffeine today. So that's going to bring us back round to you, and this was your question you asked me yesterday, number 7. Yep. Well, give me a thought. What are you thinking? Yeah, well, you definitely shouldn't be over your max heart rate. So how do we work out somebody's max heart rate? 220 minus your age. And so that brings in a very important factor. What is important for how fast is too fast to treat? The person's age. Yeah? So if they're older, do you want to be more careful with them regardless? And if you see their heart rate is getting towards their heart rate max, that is the heart rate reserve. Remember that equation? Yeah. This is the only use of it. You don't use heart rate max or heart rate reserve in training anymore, do you? In your exercise and sports science degree? They do? Ah, I thought they have some new equation that's like half a page long or something that they talk about.
No.
There's an alternative.
Yeah. Yeah. Yeah, that one. It's like, again, you pretty much end up with the same answer. Somebody got their PhD for doing nothing. That's all. But that's what people do. Research. So most importantly, the older the person is, just the more you worry about how high their heart rate is. Yeah? Like if your patient's your age, and they're 160, well, do they need physio? Yes or no? That's it. The answer is yes. Physio them. So part B is treat. There's a bunch of things we mean when we say treat. So if somebody has sputum, should we de-sputum them regardless of their heart rate? Because sputum is a problem of airway and breathing. And what comes first and foremost in resuscitation? Airway, then breathing, then circulation. So when we're talking about the problem of sputum movement, gas movement, function, always think sputum movement and gas movement, that's your job. Yeah. Now, if you can't breathe, you reckon you're going to be a bit stressed? Is that going to make you a bit tachycardic? Panic. Yeah. So what are you doing? Making their life better by making their life a bit harder for a little while. Yeah. That's all. So you can ask anyone to breathe and cough, assuming they're not looking like death. The part B of that is if they are tachycardic, there are gradations of mobilizing. Yeah. So can you just sit somebody on the edge of the bed, see what happens, and go back to bed? Yeah. That's all. If you're worried, can you stand somebody up and then sit back down and go back to bed? Yeah. Can you stand somebody up for like 1 minute and then go back to bed? Yeah. These are all the things you can do that are basically, I started in the bed and I ended up in the bed because we're very worried, but they've had surgery. So we're also very worried. Yeah. And if they're older, do they already have comorbidities? And do they also have a much higher likelihood of atelectasis and all those other words? Yeah, because they're older. Yeah. Closing volume. Weird freaking concepts they teach you. You guys get taught about closing volume? It literally means if you breathe all the way out, at a certain point, some of your alveoli will close. How is that science? Yeah. Now you are, at some point, alveoli close because you're old. That moves up. That's atelectasis. That is just FRC. If you just, all you learnt was FRC and none of that other stuff, life would be easier. FRC, position, FRC. All of that. You don't have to worry about breathing if you improve FRC. Breathing takes care of itself, or you're already dead. That's all. If you can't breathe and they don't want you to die, do we have a machine that helps you breathe? Yeah. See? But you're pretty much technically already dead without the machine. If I unplug that machine, what happens? Sad face. Our machines all run on batteries, so unplugging it from the wall is not a problem. They do beep a bit. So how fast is too fast to treat? Well, think about what you're doing treatment-wise, how hard you want to push the person for all the reasons we talked about before, yeah? All of those numbers. And then, what is the age of the person? And the simplest thing of all is, what is your heart rate right now, give or take? What do you think it is? 70. What is your systolic right now? What do you think it is? Systolic. 120. So 120, 80. Yeah? Say you're exercising. What would your heart rate do? So your heart rate's 120. What do you reckon your systolic did? Yeah, 160, 150. Yeah, see, the systolic is still higher than the heart rate when you're exercising and tachycardic because you have normal function. If you are, say, massively vasodilated because of sepsis, what is your blood pressure likely to be? 150 or 100 or 90? 90. So say your systolic is 90. Do you want your systolic to be 90? So what's your heart rate going to do? So if your heart rate's 120 and your systolic is 90, is that the normal relationship? No. 120, 80. So that is downhill. Seagull sign or various other words that we use. But if your heart rate is higher than your systolic, are you in a world of hurt? So should I be very careful? Really simple.
Seagull.
Seagull. You're about to get crapped on. Not making that up. Paper charts. Literally from friends in the UK, when you had paper charts and the way they worked, it literally looked like a seagull was about to crap on you. Seagull sign. That's all? Yeah. No, treat in terms of physio. Oh, no. So say somebody is tachycardic. No, actually, we rarely talk about that. If somebody's heart rate is high, what would they do medically? Beta blockers, because you are blocking the beta what? Adrenergic receptors. Beta adrenergic receptor will do what? Well, when adrenaline hits it, what does your heart rate do? So if you block the beta adrenergic receptors, what does your heart rate do? Yeah. So the relative balance between your sympathetic and your parasympathetic. Yeah. If you're blocking the sympathetic, there's more parasympathetic. So what does your heart rate do? Go down. Yeah. Nice and simple. Digoxins, all these other drugs for heart rate. Yeah. That's it. Give them the heart rate lowering drugs if their heart rate is too high. And if your heart rate is high, causing hypertension, can I just bring down your blood pressure by reducing your heart rate? And that's your beta blockers, your metoprolols, your propranolols, and all those kind of things. Yeah, so if somebody is tachycardic in whatever form, and you don't want to treat them in the morning, but they're going to give them the drugs, do the drugs work? And if the drugs work, do you just come back in the afternoon? Yeah. Now, do the drugs work too well sometimes? That's all. And their blood pressure might be too low. Equally, so you don't do anything differently. It's equally careful with all of these things. Does that make sense? Where are we? Question 8, Sarah.
So the obvious ones were the decrease in potassium and decrease in magnesium, so less than 3.5 and less than 0.7.
So low potassium, yes. Low magnesium, yes. What about a high potassium? Oh, yeah. So a high potassium is literally how you kill a person. When I said yesterday there's only one thing that kills you, your pH, there's two things that kill you. High potassium. Acidosis, yeah. Now, how do you get somebody with a high chloride? Give them too much normal saline, because normal saline is equal parts sodium and chloride. Is your blood, and you can see it right here, is your blood normally equal parts of sodium and chloride? No, you have more sodium than chloride. And is sodium going to cause an alkali or acid? Alkali, it's an alkali metal. Yeah, so more sodium equals a pH above 7. Less sodium equals a pH less than that. Or more chloride, yeah? Because the chloride associates with the H plus ion, forming HCl, which is hydrochloric acid. And where do you find that in your body? Stomach. Does that sound good for the rest of you? Because what does it do? Ceviche, correct. Ceviche. It's the number one way to think about this. When did I learn that? In Peru. We were making ceviche, and I went, this is how I'm going to take acid base for the rest of my life. And bacon cakes. Yeah. Abnormal magnesium, or low magnesium, will cause atrial fibrillation. Very common day 3 post-cardiac surgery. Yeah. Are we going to be seeing people day 3 post-cardiac surgery? Yeah. You will spend more time with them than anyone else does, because they're pretty much ready to go for long walks. They'll go into rapid atrial fib while they're with you. It happens to everyone every week. Find a chair if they look funny, otherwise just wander back and sit them down, tell the nurse. It's just one of those things. Sometimes it's day 2, sometimes it's day 4, but it's on average day 3 post-cardiac surgery, rapid atrial fib. What do they do? Well, if their heart rate's rapid, what drugs do they give them? Beta blockers. And if their magnesium is low, what do they give them? Yeah. Now, where do you find magnesium in your house if you have it? Well, yeah, in vegetables. That's potassium. No, Epsom salts. You know your bath salts? Epsom salts. Magnesium sulfate. It probably in vegetables. Yeah. So if you have a low magnesium, there's another one of those things that people put in their baths because they're feeling crampy, and it could be placebo or it might actually help because it absorbs through your skin to decrease crampiness. The other one is low potassium will cause ventricular arrhythmias. High potassium will cause ventricular very sad face. Death by lethal injection. High potassium chloride solution. Your heart just stops. Instead of being a QRS, it's a sine wave. Does that sound like a snap or a... Yeah, does that sound like cardiac output? Sound like blood pressure? Death by lethal injection, potassium chloride. Yeah. Well, no, not at all, which is why they give you otherwise a paralyzing agent to stop you looking like you're seizing, and a sedative to stop you remembering that you're seizing. Well, hopefully, if you had actual doctors doing this properly. But this is the US where they do this. You reckon they got proper doctors doing this properly? No, the doctors refuse. So he's got some schmo that's drawing up whatever he thinks he's supposed to and giving it to some, I don't know, 400-pound dude. That's the size of a gorilla. Yeah, and just giving him the dose you'd give Arn over there because he doesn't know any better. They don't understand that, you scale things according to body mass. I don't know, Americans. Funny side note, and this was like one of the greatest, may or may not work plus placebo. When Em was pregnant, she was getting crampy, as you often do when you're pregnant because of fluid shifts and whatever. And I have a solution that I make up, which is some Epsom salts and some potassium for my chilies when they're flowering. You spray the leaves, it gets you more chilies. So she's like, I'm getting crampy, and I'm like, well, I have this thing in a spray jar, and I'd spray her legs, and her cramps would go away for a week. And then I'm getting crampy again. Yeah. It's all fully organic, whatever. Like it's all human safe because it's all food friendly. So yeah. I'm not just giving her lethal injection. A very, very, very tiny dose that you'd use to not kill a plant. And the placebo effect on a human is pretty good. Anything that messes with your electrolytes. Like if you don't have enough calcium in your life, do your muscles work? You're gonna die. Yeah. Yeah. Chloride, sodium. Sodium's mostly associated with nerves. So if you have sodium sad face, do you have nerve sad face? And then can you like stand up and walk over to the fridge? And again, what regulates all your electrolytes? Kidneys is the regulation, and then where else? What else? Where do you get your electrolytes from? Yeah, gastrointestinal tract. So anything that's GI sad face, like vomiting, diarrhea, or bleeding, is that going to mess with your electrolytes? Yeah. Is that going to kill you quickly? Kidneys will kill you slowly. Diarrhea will kill you in days. Yeah. That's all. We'll come back to that in various ways. The question 9A and 9B, where are we?
So 45 degrees. And
so head up 45 degrees, yep. Jugular venous pressure.
I read somewhere that was like, is that right?
Yeah, well, whichever one you want to look at, but yeah. I guess this is theoretically a more direct route, yeah.
And then so what hypertension, right side of heart failure, tricuspid regurgitation. Yeah.
So
restrictive pericarditis.
On that, which side of the heart does your jugular vein go to? Right. And where is your tricuspid valve? Between the right and the right ventricle. So if your valve doesn't close properly, blood comes back through that valve and then creates upward pressure in a pulse. If that makes sense. Now, what does right heart failure mean? Well, blood is going into the right atria, but not leaving it well enough. Where does the right ventricle pump to? Lungs. So if you have chronic lung sad face, does the right ventricle have to work harder? And if the right ventricle has to work harder, does it remodel in the short term? And then in the long term, does it get sad? And is that right ventricular failure? Yeah. So coronary, pulmonale. Heart sad face because of lung sad face. Right heart failure because of a chronic lung condition. So if blood is backing up your jugular vein into there and raise JVP, that is a superior vena cava problem. You also therefore have an inferior vena cava problem. And where does blood back up to from the inferior vena cava? Yeah. So how are your feet going to look? Swollen. So if somebody has really swollen ankles bilaterally, you reckon they have a right heart problem? And at the worse their ankles, you reckon the worse their heart? And the worse their heart, you reckon the worse their lungs? And when do we look at somebody's feet? When we're putting the red socks on. It's the second thing you know about a person. The first thing you know is how many words per breath. And the second thing is, back to what I tell everyone in their first week, how do we assess somebody's chest? Put some red socks on them. Check their straight leg raise while you're putting the socks on them, as we've done. If you can lift your leg up and I put the socks on, is it likely to be easy? Yeah. And if you can't do it, is it likely to be hard? The lady in cardiothoracic ICU. Yeah. One of those legs was not happy. Were her legs very swollen? Is she in cardiothoracic ICU? So what do you reckon her heart is? Happy or sad? Yeah. So it's really simple. Where are we? That place. Cardiothoracic. Heart sad face. So who has really bad chronic lungs? People on the respiratory ward. People that have had a smoking history. People that have all those fibrosis-y kind of words. Do they sound like chronic lung disease? Yeah, so across 20 years of that problem, are they going to have right heart failure? And they'll have cankles. And will they also have finger cankles? Yeah. What do we call finger cankles? Clubbing. We call it finger cankles. Because if you think about finger cankles, you think about cankles. Most importantly with all that, the worse the ankles, the worse their lungs. Be more careful. Take oxygen. Do all that kind of stuff. Have a chair to sit in. But also, you've all had a swollen ankle at some point in life. What did you do with that ankle? So if they have two swollen ankles, and if you don't elevate them both, they get more swollen. No, sorry. If you don't elevate their legs, the legs get more swollen. And then when you're trying to return them to bed, is life going to be easier or harder for you? So you're just making your life easier by finding a footstool and elevating their legs and doing the appropriate thing you should do as a physio that's looking at a swollen ankle. And you've looked at the swollen ankle because you checked that they had socks. And so on. Yeah, TED stockings, all those things. Yeah, the TED stockings, they have all sorts of things. Now, if somebody's legs are too swollen, it becomes difficult, but yeah. Yes. All of the above, unless it's not possible. Yeah? And it's one of those things that you never think about and you're like, swollen ankles. Why did they make it 3 meters and stop? Yeah, those legs tell me all about that. Yeah? Even if you don't understand how to interpret any other thing about their spirometry or whatever else, which we'll get to, that tells you a lot, the ankles. Which brings us to the next question. Ornan.
Wasn't quite sure.
That's the whole point.
Because there wasn't like the value.
Yeah, so what is their ratio?
80%.
80%. Is that normal or not normal? Yeah, so if the ratio is 80%, then it's not less than 70%. So are they obstructive? No. Now, the next number that's very important is the FVC. What's some things that determine what somebody's FVC should be? And? Height. Yes, body weight. Yeah. So if this was, say, a 70-year-old, 5'0" lady, would that be a decent FVC? Probably. If this was Chad, would that be a decent FVC? So if Chad had an FVC of 2 liters, would that be less than 70% of predicted? Yeah. And would he have what kind of problem? Restrictive. Restriction can't get gas in. Obstructive can't get gas out quickly. Yeah? So if you can't get gas in, you have a restrictive pattern. Is me asking you to take deep breaths going to help? Because you can't. Are you going to get short of breath really quickly when we try and do stuff? Yeah. So should I have somewhere for you to sit down on when you get short of breath, or bring the oxygen or whatever? Yeah. Now, if you have somebody with an obstructive pattern, can they get gas in? Yeah. But can they get gas out easily? No. So should you be asking them to take deep breaths? Because it would be bad for them, particularly that good old inspiratory hold thing. Yeah? Does that make sense? That's why deep breaths aren't the answer to any question, other than what are parts 2 and 4 of ACBT. Use breathing and that kind of stuff for secretion clearance. If you want to improve somebody's gas movement, stand them up, improve their position. Yeah? Patients just do that themselves. So what is another good expiratory technique? Sorry, pursed lip breathing, for those playing along. What is another good expiratory technique other than pursed lip breathing? That's for helping dome the diaphragm, but what's another expiratory technique? PEP. PEP devices, Arcapella or Bubble Pep or Syringe Pep or any of those things. Syringe Pep's brilliant. You get a big syringe, pull the plunger out of it, and now you've got what looks like a trumpet. Put the big end to their mouth, and you've got the tiny end at the other end, and when they blow, like a trumpet, you get PEP. Yeah. Do you get a known or controlled amount of PEP? No. But do you have to deal with an Arcapella or water or anything else? So is it like it takes 6 seconds to make and 6 seconds to teach them? Yeah. And the instructions are blow like a trumpet. They're impossible to get wrong, they just can't do it. And it's much harder to hurt somebody with one. Yeah? So we do that all the time. Particularly like our patients that you're going to see that have had abdo surgery. Are they allowed to drink water? No. And if they're not allowed to drink water, should you give them a bubble pep? Because then we'll get in trouble. Can you give them pep without water? Yeah, syringe pep. That's all. Literally pull apart a syringe. A big one, like the 50 ml ones. Yeah. So, the pattern is either it's low or it isn't. You can have no problems, one problem, other problem, or two problems. Yeah. Either way, we often check these for people before cardiac surgery, but other than that, you're not necessarily interpreting. Troponin, where are we?
So a protein that's in charge of muscular contraction for
Yep.
both skeletal and cardiac muscle.
Yep.
And so when your cardiac muscle or your heart is damaged, they increase these so that
It increases in your blood
In
when
your blood.
cardiac muscle is damaged.
so when they measure it, they'll see more of it show
Yep.
up in your blood, which
Yep.
is like an indication that they might have a heart attack or
Yep.
something wrong with their heart.
Yeah. If you see the word troponin in a sentence, check their troponins. If it is elevated, do they have cardiac muscle damage? Yeah. And the higher the number, the more cardiac muscle damage. So troponin is tropomyosin. Yeah, myosin is just myosin like muscle. There's 3 strands of troponin in tropomyosin, and troponin T is the one specific to cardiac striated muscle and is not found in skeletal striated muscle. Yeah. And what is the point of tropomyosin? It's where calcium binds, and calcium is your, mousetrappy excitation coupling. Yeah? Don't need to know any of that other than troponin, heart, sad face. So back to all those ECG things we were saying before. If you see any of those words in a sentence, go and check their troponins. And troponin makes heart, sad face, and anything in the range of, like anything above like a non-zero amount basically, they'll say is significant. It's how significant is a whole other story. Either way, what's some other words that we'd see that mean go and check somebody's troponin? Well, if you see ECG or troponin, what else? What's some reasons why somebody would come into hospital, and what's the words they'd use to... Chest pain. Yeah, so you all described the classic symptoms for a man. Are they the classic symptoms for a woman? Yeah, that's a whole weird, vague thing. I have to find the paper on this and teach it properly at some point. But yeah, I was very much listening to, like, even in the modern day, people are just taught the typical example, which is in the 1960s, a guy having a heart attack, not anything vaguely to do with what a woman having a heart attack would look like.
Why is it different?
Because you have different physiology, you are less likely to have one below the age of 65 and all that kind of stuff. Because we'll say estrogen, but I don't remember. But,
So what other signs?
so it's going to be a lot vaguer. So therein lies the problem. If you come into hospital as a man having the classic signs, you're going to get treated for all those things really quickly. Whereas for a female, you may not. And they may not think to check troponins. They'll do an ECG, and if you have the classic ST elevation change, sure. But if you don't, as NSTEMI, non-ST elevation MI, what that means is you don't have the classic changes. So as a man, they might still do troponin because you're 55 and having classic signs, but as a woman, you might not.
So when would you go why would that be there?
They might not. This is the problem. Therein lies the problem. They don't know what the classic signs of a heart attack are, or they come in thinking it's some other thing. Like you've all had problems and downplayed them. Oh no, it's not that. It can't be that. It may be that. Might not be. Yeah, had reflux bad enough that. Yeah.
She would always say that when complaining of pressure like the stomach didn't want it.
See
Or
it.
sitting on the upper line.
Somebody sitting on them. Yeah. The impending sense of doom is the other one. Yeah. Uh-oh. And the last one, Chad. And the low end of normal for ejection fraction, so 70%, and the low end would be? Ah, okay. Less than 55. Fair enough. What does ejection fraction mean? In what sense? So the left ventricles change in size, and how would we measure ejection fraction? Yeah, yeah. End systolic, yeah, minus the diastolic on what test? Literally, that's what they're doing. Ultrasound. Yeah. So the number that they're implying is, and you were saying, is the stroke volume. That's the number you were saying, is how the actual volume. You can't measure the actual volume. You get two implied volumes because of parallax error, and the difference between them is a percentage. So if your ejection fraction is happy, do you reckon your muscle is strong and happy? Yeah. If your ejection fraction is low, is your muscle strong? No. So that's the way of thinking about that. And that comes back to stroke volume and contractility and that kind of stuff. Yeah. Now you might have a low ejection fraction because you're massively dehydrated. Yeah. If you have a low volume in your system, is there less blood in your chest? Is there less blood in your ventricle? Yeah. But the muscle itself will still look okay. So it's all part of, they look at your heart in real time and watch motion and all using an ultrasound. And so again, if you see words like this, oh, they had an ultrasound of their heart, heart sad face, or not. You can read the report, but somebody will indicate whether it's heart sad face or not. So if somebody has a low ejection fraction or a weak muscle, are they going to be having a good blood pressure or a less good blood pressure? Yeah. And so will they be having a normal heart rate or a higher heart rate or a lower heart rate? Higher heart rate. Back to higher heart rate, less pressure. Yeah? Worry about their heart rate. Is this going to be more prevalent in, say, older people? And back to why age comes into it. Yeah? Your ejection fraction creeps down with age, and therefore your cardiac output, strength, all those kind of things creep down with age. And therefore, that's why we are more careful, yeah, bringing the age into the heart rate max equation. Yeah, so you need something to help their muscle get stronger. Cardiac rehab, yeah. Or if the problem is that their heart muscle isn't getting enough blood, is that going to make your muscle weaker? So how do we get more blood to the muscle? Yeah, so drugs for that, yeah. Anginine, like literally, it's GTN, glycerin trinitrate. The drug brand name is Anginine. Angina. What does angina mean? Pain. Well, angina means pain. Angina pectoris is chest pain, but everyone just says angina to mean chest pain. Yeah. So you have the anginine for the angio thing. Yeah. So narrowed blood vessels will reduce blood flow. Yeah. What will that do to oxygen delivery to your cardiac muscle? So how do we fix the problem? Open heart surgery. 2, do a coronary artery bypass graft. Or what's the other one where they don't open your chest up? Stenting. Go in through the femoral artery or radial artery, find the thing in question, put a balloon in there to dilate it out, drop a stent in there to keep it open, put them on some drugs to stop them coagulating. Happy times. Yeah. So they go through the wrist now because they've got smaller instrumentation. Yeah. Well, they do the same thing for brain stuff. Yeah. Imagine brain sad face. If somebody's blocked an artery, can you unblock an artery? Yep. Endovascular clot retrieval is the unplugging, and TPA, tissue plasminogen activator, otherwise called thromboclotting lysis. What does lysis mean? Breakdown. Yeah.
Why do they choose between the two?
Time frame. You can do the TPA is for less than 4.5 hours. The clot retrieval they can do for more than that. So if you wake up with stroke symptoms, they don't know whether you had it an hour before you woke up or 5 hours before you woke up. Yeah? They'll still unplug you into vascular clot retrieval. But if you had, what's your signs of stroke? FAST, which stands for? Face symmetry. Arm what? Or? Coordination. What would be the problem for a coordination? Cerebellum. Yeah. That won't be a strength problem. It'll be a finding your nose problem. Yeah. That one. So arm, speech. What about it? Slurred or? Yeah, or? In what way? Yeah. So dyspraxia is the gibberish. Having no words is dysphasia. And dysarthria is the slurring. Yeah. And then roll all that into dysphagia, which is the swallowing, because that will kill you. Because swallowing is about airway protection. If you're not protecting your airway, you're going to go out like a rock star. Yeah. Why? Heroin. What does heroin do to your level of awakeness? And if your GCS is less than 8, do you protect your airway? Yeah, it's not about airway closure or airway collapse. Airway closure is good when you swallow. But if you don't swallow adequately, all the stuff that should be in your stomach is now in your lungs. Yeah? The bad thing about heroin is it makes you vomit. And when you vomit and don't protect your airway, what do? Yeah, you guys watch Breaking Bad? Yeah, Breaking Bad. Yeah. Anyway, good talk. It was good fun. See how this recording is. And